This is Residents in a Room, an official podcast of the American Society of Anesthesiologists, where we go behind the scenes to explore the world from the point of view of anesthesiology residents.
Incivility can show up for different people in different ways.
When we look at people and look at how they act afterwards, I think those are the keys to actually identifying a lot of these behaviors.
The more that we are able to contribute to having civility in the workplace, the more workplaces and the more healthcare settings we will touch.
Welcome to Residents in a Room, the podcast for residents by residents. I'm Dr. Tanisha Verneus. I'm a CA2 at Columbia, and I'm the ASA Resident Component Governing Council's DEI ambassador. I'm excited to be joined by a few residents who are here to help me explore the issue of incivility in healthcare settings. Before we dive into our conversation, let's meet our guests.
I'm Dr. Mogen Frenkel, but please call me Mogen. I am a CA3 going into private practice general anesthesia, and I'm finishing out my residency at the Medical College of Wisconsin affiliated hospitals.
Hello, everyone. My name is Dr. Zelle Ngundji. I am currently a CA1 at the University of Illinois Chicago College of Medicine. I'm excited to speak with you all today.
Hello, Mogen. I am so excited to have you here with us today and to have this conversation with you guys. So when you've all heard you're invited to be on a podcast about the cost of incivility, what were your thoughts? Be honest. Does it seem like a topic that warrants more attention, or did it strike you as peripheral somehow? I know that for me, when I was asked to host this podcast, I really had to take some time to think about what incivility was and what it meant to me, and really think about how incivility has showed up in my life, whether that be clinically or in my personal life. For those who may not know what incivility is, or maybe have not thought about incivility before, incivility is often defined as rude, disrespectful, or unprofessional behavior. Particularly, this is a definition for healthcare, and that may be done by healthcare providers, patients, or even visitors in healthcare settings. And some examples may include dismissive or condescending remarks, ignoring or excluding others, yelling, using harsh tones, undermining someone's authority. There's so many ways that incivility can show up in healthcare in general. And there's so many ways where it's pertinent in the field of anesthesiology. And initially, I wasn't sure if I really felt like I identified with this topic, but with more thought, I thought it was something that was important and something that we should have a conversation about.
I think I didn't think about it explicitly, but it's very important because it's, as I start to think about oral boards and how on the OSCIN component, there is a situation where we're evaluated on how we deal with the difficult interaction with the surgeon or a proceduralist. It is something that's at the core of our specialty. And actually in medical school, we talk about this stuff. Even in my M1 year, we talked about how we deal with difficult circumstances and how we interact with people who sometimes aren't civil, and how we either approach those situations in a professional setting, and often how we mitigate those feelings within ourselves after we leave that professional circumstance as well.
Similar to you, Dr. Verneus, I previously hadn't had thought about the topic much. Upon further reflection, I think two things come to mind when I heard the word incivility. I mean, the first was the psychological reaction to incivility, the way that people respond to it. Truth is, most people can't control how they respond to different acts of incivility. Psychologically, you might have a response that is just not as welcoming, and it can create feelings either positive or negative. And so it's important to think, how does incivility affect the mindset of others? Is there a safe psychological space for expression, acceptance, especially in a field like healthcare? And then there's also the physical response to certain behaviors. So I think both can be costly in a healthcare setting, but just to think that, especially in anesthesia, we're usually dealing with intense or high stress settings. So in those settings, along with dealing with incivility, we have to think about how do we process what we say, and how does that affect those around us?
I agree. I can think about many different situations where I myself have experienced incivility, where I myself have witnessed incivility, and there are many psychological effects of incivility. And just thinking about it, all those things come back to mind and those feelings. And so going beyond that, I mean, we're all human. We experience and we display a range of emotions, but the question really is, how far is too far? And what does incivility look like in the settings where we live and work? So I'd love to have a little bit more of a conversation about incivility within anesthesiology, within the operating rooms or the ICU settings, but also about incivility maybe in the places where we live as well.
So from a professional setting, I think it's very tough because one of the components of incivility, in my opinion at least, is it's very deeply personal. And for one person or another, the line where something becomes disrespectful or something becomes unprofessional, something becomes unacceptable varies greatly. I think there's, for the most part, things that should never be said, and there's absolutes. But barring those things, it's difficult to say. It's a gray zone, and individuals have to have a lot of self-awareness to be able to say that, wow, I think certain behaviors are really unprofessional or uncivil in others, but also being able to recognize that maybe I've crossed the line and maybe I acted in a way that provoked a certain response from someone else, whether it be someone's acting passive aggressively or someone's acting aggressively, and that's impacting patient care, or your behavior on the complete opposite end works to thwart and works to crush incivil behaviors.
Yeah, I agree with Dr. Frankel there. I think incivility can rear its head very differently in different settings. And usually it's low intensity, but can still create a negative environment. For example, it can be something as loud as interrupting or talking over people, which is not uncommon when you work in a team-based setting such as healthcare. Or it can be something as simple as ignoring someone's presence or their contributions to the team, or even rolling your eyes, sighing loudly, those nonverbal actions that can be classified as incivility. And one thing that I would like to also touch on is, Dr. Verneus, you mentioned it's a rude or disrespectful behavior, but I also think that it can be classified as something that violates social norms or can be defined as socially impolite or disrespectful. Just in different societies, different things can be considered disrespectful. And in many of the healthcare settings, we might deal with patients and coworkers who are from different cultures. And so be telling someone your truth of mind might be considered a form of respect in that you want to have that open communication, but the way that it's delivered might not be received as well from the other party. And in terms of how you know you've gone too far in civility, I think looking for social cues might be a good place to start. Are you receiving awkward looks from others after you speak? Are people starting to distance themselves after a specific conversation that might have had a certain level of tension? Or even facial expressions. Facial expressions are one thing that is universal. So those are a few things that I think can really help us know whether or not we've gone too far and have that lack of professionalism.
What I really liked that you both brought up was how incivility can show up for different people in different ways. And I also really liked how you both highlighted that it really is dependent on culture and societal norms, and it may be different for different people just because that changes how they perceive the way you interacted with them or how you may perceive how they interacted with you. And I'm curious to hear about whether you have witnessed any incivility at work from patients or from coworkers. We all know that healthcare is a high stress setting and emotions can often run high. Sometimes there are pressures as anesthesiologists from the surgeons, whether it's cases running late throughout the day and the surgeon wants to get things done, or whether it's just things are wrapping up and it just feels like we're running out of time. or maybe it's coming from the nursing staff in the operating room, or even in the pre-op area. There's so many different settings where we interact with different providers throughout the perioperative period. And there's so many situations where we may run into people being impatient as one example of how incivility may show up. So I'm curious about your own experiences, and I just want to hear a little bit more about your own stories or the stories of those around you.
Yeah, I'm happy that you brought up the example of many different people just in the work setting, right? Because the surgeons versus the main OR nurses versus the residents and the anesthesiologists, we all have, it feels like, pressures in the workplace. It's just that the pressures that we are experiencing are different. And it's not uncommon to see friction between staff, but it mostly depends on the setting. Since this is residents in the room, I'll say us as trainees, we're put in a weird place, right? Physicians in anesthesia, we deal with high acuity and emergent situations that can escalate very quickly. But as residents, sometimes we have residents who might work very long hours, especially in high stress environments. That can become emotionally tolling. And in addition to that, we're doing that with the viewpoint of working in a hierarchical structures. We have those who are kind of like the higher ups. And then we might have others that we're working with, or let's say we're working with medical students, and we have to find a way to communicate, essentially. These conditions might make communication difficult, but then it's also important to think, is incivility an excuse in these settings? And let's talk of working in work settings that might tolerate aggressive behavior. So we're put in a really weird conundrum where we're allowed to practice with enough autonomy to put in orders for patients, talk to patients and their families, make our own decisions. But then we can't take it too far because we're also limited to the point where we have to think twice before we talk back to others or make a defensive argument because we are still trainees. And quite frankly, we can't afford to screw up this early in our career. Looking at it from an outside lens, just remembering that healthcare is a team sport is something that's been personally helpful for me. We choose the type of practitioner that we want to be. We already have that mindset to know we're working in a very complex, high stress environment, but we do need to rely on each other for different skill sets and consider different solutions to get to that common goal of treating a patient.
Yeah, you brought up a lot of really good points. And I think looking back, the times where I think I was met with the most incivility were actually by patients, maybe as too bright-eyed and bushy-tailed or something. I think that surgeons, and I'm not trying to be an apologist here, but I think oftentimes they just require, just like any other relationship, just getting to know you. And I think that oftentimes surgeons have been dismissive towards me or incivil with me. They've been very quick to say, get your attending in the room or something like that. And that's totally fine. I understand that the patient has to come first. But I think over time, as I've done more cases with them, as I've established my competence with them, the relationship dynamic has also changed. And looking back, I also think one of the most important things to do is to think about how my actions and how the surgeon's actions look in the bigger picture, right? So when I walk away from a surgery, if a surgeon said something to me about patient management, about something that's going on, I don't think it was meant to be a personal attack. We're just trying to make sure that the patient has the best possible outcome. So if it's a neuro case and the blood pressures are too high, or we need to hyperventilate more or something like that, I totally understand that. However, if it's a personal attack or something like that, that's completely different. And that takes a completely different frame of mind to approach. And you're completely right. It's in these moments where we define ourselves as physicians. And in those instances when less than savory things have been said, I think that having an attending that sticks up for you, or having individuals to recognize that, hey, that wasn't right. Even having the circulator nurse say, it's like, hey, that wasn't about you. That's just them or they're just frustrated, helps to validate your own feelings and realizing that, hey, that wasn't about me. I'm actually doing okay. This was just maybe misdirected anger. but also validates that the surgeon perhaps may be acting unprofessionally as well.
I couldn't agree more.
I also agree. I think one of the most important things when you are in these situations is that validation, where you just want to know that someone sees you and that someone hears you when these things or these moments become so intense and when things are hard. And maybe you leave those interactions feeling poorly about it. And I also agree that at the end of the day, what we have to remember when we're in the operating room or whether we're in the intensive care unit is that we are all here for the patient and we all have one goal, one overarching goal, which is to make sure that the patient has this procedure, that they are safe during the procedure, that they're comfortable. The surgeon needs to do their surgery, but our job is also to look out for the patient. And one of the reasons why I wanted to become an anesthesiologist was because I really admired our ability to advocate for patients who are under anesthesia and who cannot advocate for themselves. And what I find in these situations where I feel like there's been some form of incivility is that sometimes when you're in these moments, it's so hard for you to separate that emotional piece that we kind of talked about a little bit earlier. And although, right, we all have this goal of getting the patient this procedure that they need in the most safe and efficient way as possible, it's so important to remember that we're also people ourselves and that each of these little interactions impacts the way that we show up for our patients in those moments as well. So I think, yes, it's so important to give people grace and know that, maybe they're experiencing high, intense emotions, but it's also important to recognize as a bystander when maybe someone else is wrong, and also important to recognize as the person experiencing that, how we feel in those moments, while also allowing ourselves to recenter and focus on what's happening in front of us at that time.
And what's really challenging in anesthesia, especially, is that the surgeon, at least, or the surgical resident, fellow, et cetera, proceduralist, whomever, they're all working in teams. And oftentimes we're the only representative of anesthesia in the room. So it's tough because we're working almost in a silo and they're working in a team. So getting that self-validation or that realizing, hey, this was a really crummy circumstance. I need to take a moment or something to recenter myself so I can give the patient better care is vitally important.
So now that we've kind of shifted to talking about our patients, I want to talk a little bit more about how incivility hurts our patients. What is the cost to the people that we aim to heal when we're in these tense environments? And the tension isn't just from the procedure that's happening or the anesthetic care that we're providing, but the tension is more so interpersonal amongst everyone else in the room.
Yeah, so I think Dr. Frenkel just kind of hit the nail on the head when he spoke of just, surgeons or surgery teams and proceduralists work in a team setting. So it's easy to have that support. But with anesthesia, usually you're the only provider in the room traditionally. And because of that, it can really feel like you are fighting a battle on your own. But again, it shouldn't feel like that because it's a team setting and we're all there for the patient. So incivility can in fact be harmful in that it can cause unnecessary stress to the providers that are all trying to care for the patient. And this can lead to low performance, especially in settings where tensions are already high, for example, in the ICU or in emergent situation. In terms of patient safety, this can just lead to things like less collaboration and communication, let's say, between the anesthesia team and the surgery team. And this can often lead to medical errors, or it can just cause a defect in the staff's well-being, right? It can cause increased burnout, increased stress, and overall job dissatisfaction. And if we want to take that a little bit further, it's likely even lead to more turnover in the workplace, absenteeism, just due to there being a toxic workplace, as it's traditionally called. And patients sometimes can feel that. They can feel the tension or the energy in the room. And I'm sure that in turn can also lead to less patient satisfaction. And I actually was opportune to come by some info from the ASA regarding this topic. So if anyone is interested in learning more about the topic, I just highly encourage you guys to check out the ASA newsroom press release. It was released in November of last year. It's on harassment, incivility, and disrespect in the workplace, and essentially just discusses how this topic contributes to the anesthesia workforce, shortage and compromising patient safety. And it includes action items on both an individual and an organizational level on how to address this topic in practice.
Yeah, and actually, when I got the email about this podcast, I did some digging too. And in 2019, this person, Katz, did a study, and they gathered 76 anesthesia residences between CA1 and 3s, and they broke them into two groups. And one of the groups was a control, and the other was a rude. And in the rude group, basically a surgeon would say something along the lines of, someone ought to know those vitals or know what's going on. And the situation or the scenario was basically a hidden bleed during a laparotomy in a high fidelity OR simulator. And what they found was in the control group at least, of the people that did it, 91% passed the simulation. Whereas those exposed to the rude comments from the surgeon, only 63% of those people passed. They actually did a subgroup analysis, and they saw that the residents exposed to rudeness scored lower on every domain, but particularly in diagnosis and communication. Though they also did some regression, and they actually found that incivility was the only significant predictor of failure. So to the points that are brought up, yeah, incivility is really detrimental, especially in training, because it thwarts and it stymies any further development, and especially learning how to act in those high fidelity situations. Whereas if you're in a great situation with a fantastic collegial support, you can learn a lot. You can work with your trauma surgeons. If you're in a significant trauma where there's bleeding, you could work together to balance resuscitation. They could even potentially teach you how to do surgical lines such as a subclavian, non-ultrasound guided central line. But if incivility is approached in such a way where individuals don't feel empowered, they don't feel like they have the tools or the support around them, they won't be able to grow, and they won't be able to really flourish as trainees.
That's a great point. That's an interesting study too. Many people think that a lot of the learning and the progression of, I guess, the workplace, or just really just being an effective team and having effective results, might come from being at an academic institution. But even in, for example, private practice, the best thing that we can do is, like you said, learn each other, communicate, and open up the learning environment, because the more that we learn from our surgeons and the more that the nurses learn from us, and just all in all, the more that we can really actually help one another out. If I know a specific surgeon likes to do things this way, they don't like giving certain drugs, they don't like certain, I don't know, airway types. And if the surgeon also knows what things the anesthesia team prefers, I think it just helps with the efficiency and the flow of the workplace. And all in all, just making the workday easier and more tolerable for everyone, quicker and more efficient for everyone, and just more enjoyable for everyone and for the patient as well.
I think just the most important thing is just communication. And oftentimes, I think we judge others by what they say and ourselves by intentions. And sometimes I think that we have to also look at the intention of what's being said, how it's being said, the situation, just give it more context. Because when things happen in a vacuum, I think that's when sometimes feelings get hurt.
I think that's really powerful to think about that study, and really just how incivility can stop residents or surgeons or attendings, right, anesthesiologists, from really reaching their full potential. And I think it just goes back to thinking about really just, again, like all those costs of incivility, which we touched upon before, whether that is the decreased job satisfaction, burnout, and all those things. And really thinking about this operating room as a shared setting where we're all there to not only care for the patient, but also to learn and to grow in our careers in order to be able to provide better care for patients. And I really liked that you highlighted how important communication is, and really just also remembering that we are existing in this room during these interactions, and we are all people beyond this room. And just because we are one way in the high intense situations that may be happening when incivility really shows up in our workplace, that doesn't mean that we're that way outside of the workroom. And really just, again, like taking the time to give each other grace and recenter and focus on the patient. So my next question is a little bit more so about how can we remain civil when we're being pushed too far in these situations? And ultimately, should we remain civil when we are being pushed too far?
So I think there's a few different ways that we can try to remain civil and hold ourselves accountable, right? The first is just having just that accountability partner. I think both in and out of the workplace, it doesn't hurt to just ask, was anything I said or did offensive? And when you ask that, it really does provide a room for growth. And I also think it matters who you ask, right? Are you asking people who think like you that will essentially just contribute more to groupthink? Or are you asking someone who's your superior that can be honest with you and hold you accountable? Or are you asking someone who might work at the same level as you, or who you are their superior, in which case you have to ask yourself, are they too intimidated to offer negative feedback to me? Essentially, you just want to, whatever it is or whoever it is that you choose to hold you accountable, you'd want to create a safe psychological environment for them to respond. You want to give them time to answer and also take their advice and opinions on board and incorporate it right into changes in your practice. Another way would be different experiences and interactions. I can personally say that I think many institutions train us on professionalism, how to build team structures, communicate, like we said, conflict resolution. But let's be honest, how many of us actively recall this information when we're interacting with coworkers on the unit or taking care of patients? I think it's difficult to teach emotional intelligence on a PowerPoint. The truth is, many of us bring learned habits into the workplace, and we learn to adjust every day by our different experiences and interactions. And then lastly is just leadership modeling. I think we discussed earlier, working with those attendings who are just pleasurable to work with. You can see their passion for teaching. You can see that they genuinely want you to learn. There's a saying from my hometown in Maryland. They used to say, each one teach one. And just recognizing that commendable behavior of people around us, such as our attending, and modeling that for our peers. Intervening consistently when we recognize that there is incivility in the workplace, and promoting a culture of respect, just inclusion, and giving others that psychological safety is really important so we can learn from others and others can learn from us as well.
I think there's a time and a place to address these things, right? If a patient is hemorrhaging, bleeding out, people may say things that they don't mean or that they regret. And I think at that point, it's not the situation to say, it's like, hey, let's talk about it. But at the same time, I think that following that encounter, I think it's imperative to discuss it. And even if it's with a senior attending, even if it's with a surgeon, I think that it falls on us as we become senior and hopefully with the support of our own faculty to say something. And I think in today's current medical training culture, such actions are actually supported by residency programs and even by GME offices as a whole.
Yeah, I would agree. I think that change in the culture of training is actually very helpful because it just makes it easier for us to ask questions as learners and as trainees. In training, we only have a certain amount of days to learn everything that we need to know to be efficient providers. And if the space isn't open for us to create dialogue with our attending, Ask them questions that might even seem quote unquote dumb or that might seem intuitive. There's no way that we can really grow and learn. So just, yeah, I completely agree with you. I think that culture change really does allow for better learning, healthier learning, and more motivation to ask questions and build on the knowledge base and foundation that we already have.
One of the things that I find really helpful is just the opportunity to debrief when I leave the OR, whether it's debriefing with my co-residents in our group chat. And like, it's always been really helpful for me to say, oh, this happens to me today. What are your thoughts on this? Or has anyone experienced this? And going back to that same piece of validation, where someone can say, yes, this happened to me, or maybe not, but this is how I would have dealt with this. This is what I think you can do. There have been times when I've had really stressful, like hard interactions, and it's really helpful to have someone that you can speak to. But really, it's up to the organization and the institution to provide the space for us to debrief and for us to provide feedback on these experiences and to move forward from there and just have mechanisms in place for how we can take action and how we can make changes to ensure that this doesn't continue to occur.
That's such a great point. And oftentimes, I think some of the lessons that we learn, they don't always have to be positive lessons. I kind of have this positivity bias where I try to make the best of every situation. And sometimes we just need to accept that, hey, that didn't go as well as we wanted to, or hey, that, I don't think that this interaction is going to work well if we're in a really dramatic or traumatic operating room and the tensions are high or something's happening. We can't change that, but we can change how we approach it and the way that we feel about it. And realistically, hospitals and systems are actually encouraging more and more of us to talk about it, either with an ombudsperson or others. Just when you really want to break it down to brass tacks for a financial reason, because ultimately operating rooms bring in up to 70% sometimes of a institution's revenue. And those operating rooms can't run without anesthesia staff oftentimes. And to turn over an anesthesiologist, to get them to bring in someone new, to train them, to have them establish those relationships, all of those soft skills that come outside of just the simple practice, they can cost up to $1 million per physician for the American Medical Association.
Wow, that's impressive. I actually didn't know those statistics. Anesthesiologists have such a wide impact in the hospital and in the healthcare setting in general, right? We work everywhere, right? We have wide impact, whether it's with pediatrics, whether it's with floor nurses or in the emergency department, OBGYN, trauma, working with cardiothoracic surgeons. So the more that we are able to contribute to having civility in the workplace, the more workplaces and the more healthcare settings we will touch, because we are the common denominator in a lot of hospitals and a lot of healthcare settings, which apparently just in the ORs itself can impact up to 70% of the hospital. So just remembering that if we truly set our minds to becoming more civil, we will probably touch a lot more patients and healthcare workers than almost any other specialty.
I agree completely with that. We are truly one of the unique specialties where we do interact with basically everything and everyone. I think we have to carry the skill set of treating everyone around us and ourselves with respect, but also having to, honestly, sometimes just laughing about certain situations is how I get through it. I think at the end of the day, we just really have to remember it's not an us versus them. It's not you versus me, anesthesia versus surgery. I mean, we know that anesthesia would win because, as one of my attendings so cordially said once, while the surgeons think that they are the captains of the ship, we are the sea. It's funny in that regard. We all are there for the patient. And we have to remember that we are all doing everything we can every single day to make sure that the patient thrives. And there's a huge responsibility there. And I think that as anesthesiologists, we have the unique responsibility where we see the entire gamut of those individuals.
As anesthesiologists, we are certainly leaders, and we are in so many different spaces, able to be role models in the ICU and the perioperative space in our outpatient clinics. And I really thank you both for such an incredible conversation. But before we wrap up, I just have one final question. If you had a magic wand you could wave to spread a single characteristic across the globe, what would it be? Or, to put it differently, finish the sentence in one word. I wish people everywhere were more blank.
Yeah, this is a great question. If I had a magic wand, I think I would spread more humility. I think many, especially those of us in medicine, we don't realize that humility doesn't mean a lack of confidence. Humility means recognizing your strengths without boasting about them, being open to learning despite how much you think you may already know, having a constant drive to be better and learn from others in different situations, and just giving room for gratitude and being appreciative of others and life in general. It brings the best out of most situations when you're humble. And I have a really great co-resident who a few months ago, she said, I love asking questions, even if they're dumb questions, because that's the way that I learn, right? I'm not afraid to ask a dumb question. And when she said that, it really brought things to light for me, because I equally felt that I can walk around and ask dumb questions, quote unquote, to any attending, and immediately the response will basically be, that question is not dumb. Either I was waiting for you to ask that, or I was hoping you would think about that and consider that before you gave a certain drug or chose to do a certain technique for something. Having that humility to say, I don't know something, I need to learn. And I more than likely need to learn it from someone who knows probably just as much as me, more than me, or just knows the space better than I do. And it doesn't always have to be that our learning is from attendings. It can be from our peers. It can be from the OR nurses. It can be from the techs. All of these people are usually very experienced and are willing and would love to teach you. People love sharing the knowledge of things that they're good at. It's a gift to be around people that want to teach, and we should definitely take advantage of that.
I love that you said that. It definitely takes a village to make an anesthesiologist. And it's incredible how, looking back now, how many things I've learned from so many different people. Like, I learned how to place IVs thanks to one of the techs at our local VA. I learned how to bag mask from one of the CRNAs. I learned so many different skills from so many different people, because ultimately in anesthesia, especially, experience is so important. And just picking up tidbits wherever you can and staying open is so important. But if I had a magic wand, I would try to make more people self-aware, because I think with technology, and I think with the distancing, especially after COVID, having more Zoom meetings, having more everything, we don't get to see the reactions to our actions. So if we were to say something mean, if we were to text something mean, or it doesn't have to be mean, but maybe it's just something that's misconstrued, we don't get to see that reaction. And that reaction could define a relationship potentially. So I think being self-aware of how we say things, how we phrase things, how we interact with others is so vital, because ultimately that the relationships around us is how we approach patient care. And by working to foster those relationships, to make sure that we're all in sync and we're all acting as a true team, is so important. And sometimes tone can really be lost in an email. Sometimes tone can really be lost in a text. That's why a lot of my mentors go out of their way to either talk on the phone when we're staffing, or if they're having a difficult case, to really meet with everyone together, not just email. I think that it builds the self-awareness and also fosters a lot of those relationships, which are vital for fantastic patient care.
Humility and self-awareness, I think, are such great characteristics that will help to make us better physicians, better friends and family members, and really just better members of our community. If I were to add one more characteristic to these other two, I would say I wish we were more empathetic. I think that having more empathy really just provides us with the opportunity to relate to the people who are in front of us, whether they be our patients, and we can think about where they've come from, what they've gone through, and why they are presenting the way that they are to us, or whether it's to our surgical colleagues or to our attendings or our co-residents. I have so much gratitude, as you both have mentioned, for how much I've learned from my attendings, whether they're surgical attendings, anesthesiology attendings, as an intern across the many different specialties that we rotated on, from my co-residents, whether they're younger than me or older than me, and even from my patients and all of the support staff that I work alongside in the hospital, the nurses. And I just want to say, as one last thing, is we talked about incivility in this episode, but despite those moments of incivility, there are so many moments where we come together as a team in the operating room to fight for our patients, whether it's a patient who's having massive blood loss, and we are coming together to provide to get surgical control and to provide whatever support they need, whether it's pressors or whether it's blood products. And at the end of the day, the triumph as a team that comes together, that we were in this together and we were successful and we fought for that patient's life, I think are the moments that really make this job incredible. And so despite, those moments of incivility, we really do come together, and those are special moments as well. So I think we're just about out of time. So I just want to thank you both for your perspectives, for sharing your stories. It was really great having you both on our episode today and on this podcast.
Thank you so much for having me. It was a lot of fun.
Thank you for having me. This was great.
And to our listeners, thank you for joining us. We hope you come back soon for more Residents in a Room, the podcast for residents by residents.
A lot happens over your CA1 to CA3 years, but it's all doable if you focus on a few priorities and press pause on the rest. Know what happens when and what can wait with a resident's roadmap to becoming an anesthesiologist. Explore your milestones at asahq.org/roadmap. Join us for Residents in a Room, where we'll share timely info, advice, and resources designed to help residents succeed in residency and beyond. Find us wherever you get your podcasts or visit asahq.org/podcasts for more.